it's recording now. Now it's not recording. Okay. Whew. Okay, here we go. So a lot of times they'll have to, they have a question about puberty and just a transitional stage between childhood and sexual maturity. And what it does, it involves the changes in the whole body and, of course, the brain, the psychic, and how the person feels. And a person matures. And, as we know, women become capable of reproducing. And then the secondary sex characteristics appear. And it ends when mature sperms are formed in males, and the menstrual cycles become regular in females. Okay, so let's just go here to testosterone, which is your male hormone. So I would just write down testosterone, male hormone. And what it does, it increases the muscle mass and strength of the young man and promotes growth of long bones. This is where they get what? Tall, right? And increases the basal metabolic rate and enhances productions of red blood cells. Okay. And then, those in vocal cords, they do enlarge. And, your young boys, they had a high pitch. And now they may come in and say, hi, mom. All right. Because now their vocal cords have changed. And again, affects the distribution of body hair. In the female now, we have like the mons pubis, which is the fatty tissue on top, the clitoris, and then you have your labia majora and labia minor. And then down here in the perineum, this is an obstetrical perineum, or the fourche, as it's called. This is where, when we do an episiotomy, this is what gets cut during the episiotomy time. And of course, in here is the vagina, and here is your urethra. Okay, so just a fast review of that. So we know what the urethra is for. It's for exit for urine, and the hymen, the thin elastic membrane that closes the vagina from the vestibule. And then you have your Bartholin glands. And these come in handy, especially when you're pregnant and you start lubricating the introitus. It is good for sexual harassment, but also for in labor or in pregnancy to get her ready, the vagina ready for childbirth. Now, your perineum, like I said, allows stretching for birth and the sited episiotomy. Okay. So on this one, I always like this picture of the internal female reproductive organs, because this shows you the fallopian tubes, and here is the cervix, here's the uterus, and here's the bladder. And the bladder lays right underneath the uterus. So see, when the bladder gets inflamed and she gets cystitis, that's why we have to be so careful, when she comes in all the time in the clinics. You want to make sure that you're picking up any kind of urinary tract infection, because when the bladder gets inflamed, it starts to make the uterus contract, and then it can throw her into preterm labor. So the uterus is an important organ. A fertilized ovum implants and develops into an embryo. Remember, where does fertilization occur? Anybody know?
In the fallopian, is it the fallopian tube?
You got it, in the fallopian tubes. And then that fertilized ovum, he kind of travels right through the fallopian tube and gets implants. Implantation occurs where?
In the uterus?
Yeah, the uterus. Upper, you got it. The upper portion of the uterus on the posterior wall. And you want to kind of, on the posterior wall, think about it. You want it to have a good place for that blastocyst to really implant and to grow. And what happens? It grows and it develops into the embryo. The embryonic development stage is week 2 through week 8. So write that down. That could be important. Week 2 through week 8. And then the fetal development time starts then week 9 all the way to birth. Okay? So, and the uterus is, you ever see a pear? You put an upside down pear. Okay? That's what the uterus looks like. And it lies between the urinary bladder and the rectum above the vagina. Okay. So, and the uterus has a lot of motor and nerve roots. And that's why, unfortunately, labor is so painful. you know, because it has so many nerves down there. All right, then here's our uterus, okay? And the top portion of the uterus is called the fundus. Fundus, write that down. Fundus, the fundus. That's the top portion, because you're going to be referring to the fundus quite a bit as we study maternity. And then the inside of the lining of the uterus is called the endometrium. Okay, endometrium, that's the inside. And you might hear that being referred to quite a bit. And then here, let me make this a little bit bigger so you can see it. Here you have your fallopian tube. And you know, fallopian tubes, they're not very big, as you can see. And so, you know, it has to make its way. So here's your ovary, okay? And all these little follicles. So when a follicle matures, then it's released by the ovary, and these little fingers, fembrae, they grab, okay? And then that little oocyte is like right here, and it travels, all right? And then it goes under cell division, mitosis, right? And then it keeps dividing into meiosis, cell division, and it gets to be, let's say, fertilization occurs right around this area here, the ampulla of the fallopian tube. And then it travels and it turns into, you know, again, cell division, it turns into a morella just around this portion here. And then as it gets into the uterus, it turns into what we call a blastocyst. And then that finds its way into the upper portion of the uterus and the posterior wall, and that's called implantation. So I would really, and I think you know it, but just write down implantation and fertilization. Those are always good questions on an exam. Okay. And we know the cervix, that's the neck or the lower portion of the uterus. Here's the cervix, okay? And the cervix, just to let you know, has two osses, OS. They have internal os and external os, okay? Okay. And now let me make this a little smaller here, go back to normal. The fallopian tubes, okay? And so what a good question could be about the passage. What is the passageway for sperms to meet the ovum? And that would be your fallopian tube. Okay. Okay. So that's how a lot of times they put it. What is the passageway? The passageway for your sperm to meet the ovum is your fallopian tube. It's a site of fertilization, like we said. And it's a safe, nourishing environment for the ovum or zygote. You know, it really is a good place to be. And then it transports the ovum of the zygote to the corpus of the uterus. All right, we got that. All right. Here's our ovary. So the ovaries look like an almond. So I put an almond in here, okay? They're like, they're shaped like an almond. They have the size of a walnut, and they're held in place by the ovarian and uterine ligaments. Yeah, those ligaments, then that broad ligament, like in one of the pictures, they're quite big. But the same ligaments that hold up a non-pregnant uterus will also hold up a pregnant uterus. And that's why sometimes women complain during pregnancy of ligament pain. And usually they say it's in their groin, and it actually can radiate right down the leg. Now the ovaries have two hormones, and they're called estrogen and progesterone, okay? And just let you know that at birth, every female has all the ovums that she ever is going to have throughout her reproductive years. And you know what? It's about 2 million. That's quite a bit. Okay. So we have some different types of female pelvises. And here they are. There's the gynecoid, the android, the android orthopoid, and the platypoid. Okay, now what I want you to know is the gynecoid is the most favorable for vaginal delivery. Now this platytoid is unfavorable for vaginal delivery. You can see here the shape of it. So imagine you had tried to get a baby's head through there. Be kind of hard. And look at this one. This is really hard. Don't forget, baby's head, even though they can mold, you know, it allows them the tissue, connective tissue allows it to mold, you could very hard to get that through. And the android here, this is more of a male pelvis. And so it'd be hard to get a baby's head. So the gynecoid, you can see how nice this would be for the baby to get through. So I would definitely write down gynecoid, the most favorable for vaginal delivery. All right, so if I was to ask you a question, this is how it could be asked. The nurse is teaching health class about 4 types of female pelvises. Which pelvis is optimal for the passage of the fetal head? Which one would you tell me?
A.
Hey, good. Gynecoid. Okay, good. Okay, now the breast. The function of the breast is to produce milk after birth. Okay, and they provides nourishment for the infant, and it has some good maternal antibodies for the infant. And you'll probably get this more as we get into newborn and discuss newborn. That's the one of the benefits for the infant is to get mom's milk. Remember, breast is always best. Breast size does not matter. Sometimes they have a test question on that too, kind of throw you off. Breast size does not matter. No, it's because you have Montgomery glands, and you can see it in here, and you can see how all these different glands, it doesn't matter how size the breast is, that these Montgomery glands, and they all work together, and the hormones that needed for breastfeeding, for producing milk, would be your prolactin and oxytocin. Okay, let me go here. So we have the menstrual cycle, and it consists of regular changes in secretion of the anterior pituitary gland. Okay, so for like follicle stimulating hormone, or FSH, and luteinizing hormone, all come from the anterior pituitary gland. Okay, and of course they govern from the ovary and the endometrial lining of the uterus. The endometrium, the inner lining of the uterus. Okay, so when you don't have a period, what your body does, that these hormones make a beautiful like a velveteen situation inside the uterus, okay, with blood. And what it's doing is preparing the inside the uterus for implantation. Okay, so then she ovulates, and she has sexual intercourse during that time, and so then she gets pregnant. She has fertilization occurs, and then that oocyte moves along the fallopian tubes and goes right inside that uterus, and that beautiful lining, that intrametrial lining, that all these hormones were getting you ready for. Okay, so but if you don't get pregnant, then what sloughs off, and we see it as blood, that's your period. That's all the inner lining of that endometrium that was being, formalized during the time you didn't have a period, and then she didn't get pregnant, so then it sloughs off. So it's pretty interesting to see what happens on that. Okay, so in an ovarian cycle, what day is ovulation in a regular 28-day cycle? Do you know that? So like she has a 28-day cycle. When would she ovulate?
Would it be day 14?
You got it. You understand it. So this is what I was talking about. Here is the uterus, and see here, okay. And ovarian cycle is when the ovary releases the little oocyte, and she comes up into the fallopian tubes. And so meanwhile, see over here, all this nice cicature, all this lining of the uterus was getting ready. All right, see ovulation here, and everything's ready for implantation. But if nothing occurs, then it gets sloughed off in the menses, and that's what it's all about. All righty. Let's see here. We talked about the development of the breasts. Okay, obviously for a young girl, when she develops into a woman, and she gets her first menstrual period, it's called menarche. Okay, it's usually around 11 to 15, and that's only kind of an average age. Some of the girls go a little younger today because of the different hormones that are in foods. They get a little more. Their breasts occur earlier too, but you have growth spurts. And usually growth spurts are earlier than the male. her hips were broad, and getting ready. That's what a woman's made for, is to reproduce, right? Okay. So we talked about ovulation, and you're really good. You knew about the 14 days. Okay, so keep that in mind. 14 days before the onset of your menstrual period. Good. Okay. And a lot of ladies, you need to know that in order to, help them, maybe come up with birth control. If they don't want to get pregnant and they're doing a natural birth control, they need to know when they ovulate. Okay. And their ovulation is when it's set to go. Everything is good. All righty. So my little nursing tip for young ladies is when you're doing some sexual counseling, like I said, the nurse should emphasize that the survival time of sperm that's ejaculated into the area of the cervix, they can live up to 5 days. And that pregnancy can occur within, of course, as long as 5 days before ovulation. So the poor thing, you get a calendar and you map all this out for these young ladies, and knowing that these sperms can live up there for such a long time, that she could be at risk for getting pregnant. Okay. Now we're going to move into chapter 3, into fetal development. Okay. So just refresh. We have the body cell, which is the DNA and the nucleus controls cell function. The genes and chromosomes have a DNA, and they determine everybody's individual traits. That's why we're not identical. We're all individuals, but we all have 46 chromosomes. Okay. So you have your chromosomes from the sperm, and you have the chromosomes from the oocyte, and you have you have 23 from each, and so it comes together through 46. And during the time that, you're getting pregnant and you really don't realize, what's happening, a lot of things can influence these chromosomes. A lot of things can change and be what we call a teratogen to the embryo. And so it's always it's lovely to know when you're newly pregnant, like in the very beginning of pregnancy, because then you can, you don't use the drugs, you would eat properly and no smoking, and then we wouldn't have any problems with teratogens during pregnancy. But that doesn't happen. That's always good. For preconception counseling was always nice. Now, fertilization, like we said before, occurs when a sperm penetrates an ovum. It only takes one sperm, okay, just one, and that lucky guy gets into the oocyte, and that's it. And then the ovum, what she does, she puts like an aura around her, and so no other sperms can get in there. We said fertilization takes place in the outer third of the fallopian tube, okay, and that's called the ampulla. And as soon as it occurs, there's a chemical change in the membrane around the ovum and prevents further sperm from penetrating the ovum. I kind of just said that, but here it just shows you a picture, and it allows just the massive cell division going on now, as that travels into the ovum, travels through the fallopian tube and into the uterus. Okay, so here's my good picture. So this is on fertilization. Here's all your follicles, okay? It matures, then it releases from the ovary. Then it comes up into the fallopian tubes. The membranes, they're like little finger likes, and they will grab onto it. And here's your oocyte, okay? And here's fertilization. So you can see there's a whole bunch of sperms trying to get in, but only one is allowed inside. And then what happens then? She turns into a little zygote, as you can see, and then you have this massive cell division. So you have a 2-cell, then you go to a 4-cell, then you got an 8-cell, and then it turns into a morella. And then as you travel more into days go on, and you get in now, she's gonna look for a good place to implant. And that would be in that posterior wall of the uterus. See, that's really good. So that's a nice picture. It's important that this little guy, this these little cells here, he gets through the fallopian tube. Because if he doesn't get through the fallopian tube and it gets stuck in the fallopian tube, then what happens, it becomes what we call an ectopic pregnancy. And that's one of the topics in chapter 5 with complications during the pregnancy. It's called ectopic. It doesn't get through. Maybe there's some scar tissue. Maybe it's a little deformity in that tube that she was born with, and so it doesn't get through. And then she has ectopic. But right now we're going to say they get through. So then we went over implantation. We did all that. Okay, here we go. And we did implantation and how it attaches to the wall of the uterus. We got it. Okay. Now the first hormone that is able to pick up the pregnancy is HCG, human chorionic gonadotropin. That's the first hormone that's detectable in the maternal blood as soon as implantation occurs. That's usually 7 to 9 days after fertilization. And so HCG can be obtained by either serum or urine. When you do a serum test in the blood, you can do a quantitative and qualitative HCGs on that blood. But just know that HCG is the first hormone that can be detectable to determine pregnancy. Okay. All right. Now, sex determination, the gender of a baby is determined by the father's sperm. Okay. The pH of the female reproductive tract influences the survival rate of the X and Y bearing sperms, and even includes the speed of motility of the sperms. So if you have an XX, you have a female, and XY will result in a male. All right. Now, sometimes, the sex of a child becomes an issue. I always tell the father when he says something in the delivery room, it's your sperm that determines the gender of this baby. I had, for instance, let me tell you a little story. I had a little instance in the delivery room where, the couple had like 5 girls, right? And he wanted a male, and so she had another girl. She had a beautiful labor and delivery, had another girl, and he was very upset. And so I reminded him that it was his sperm that did it. Now, just going over real quick about the chorion. Lisa, you got the chorion, you got the amnion, all different parts of the trophoblast. And so what happens is that the embryo is in part of all this, so the amnion, the embryo, and the yolk sac. Okay. And then the embryonic portion is the fetal portion of the placenta. Everything has a role in this. Okay. And then we have the amnion, and the amnion is the second membrane. It's a thin structure that kind of, it takes in the embryo. It protects the embryo. Okay. So together, the chorion and the amnion form an amniotic sac. Okay. And in your book, you have a really good picture of this. And so it forms an amniotic sac, and that's where we know it fills up with fluid, which would be the bag of waters. Now, I put this in red because I want you to remember this. Amniotic fluid is clear, okay? It might have a little bit of tinge of a mild odor, but nothing really too much, okay? And then it has maybe Bissa Vernix, Vernix caseosa, which is the baby's, I call that baby's cold cream. It's the thick white cream that's all over the baby to protect the baby in the uterus during pregnancy. And then the langugo is the little fine hair. So write those terms down because those would be good test questions too. The Vernix caseosa and langugo, which is little fine hairs that protect the baby's skin. Remember, the baby is in water, in this bag of water called the amniotic fluid, for 9 months. And so you have to protect the skin. Otherwise, the skin would be all shriveled up, peely, and baby couldn't survive, okay? Because the amniotic fluid does definitely has several functions, and protecting the fetus is one. Okay. And as we talk about that, this is really important. I know you'll see this again, guys, so heads up, the functions of the amniotic fluid. So what it does, it helps to maintain an even temperature inside, okay? Don't forget this little guy is inside the fluid here, all right? So this amniotic fluid keeps the temperature nice and warm for the baby, all right? And then it prevents the amniotic sac from actually sticking or adhering to the fetal skin. So if you didn't have this water in here, this baby could be, could his skin get stuck to the sac, which would never be good because then you couldn't have growth. And then the amniotic fluid allows for symmetrical growth of the fetus. So like this little arm and the little arm will grow evenly. And this little leg here and his other little leg will grow again symmetrical. And again, that's the amniotic fluid that does that. The amniotic fluid allows for fetal movement, all right, and allows the baby to kind of be more what we call buoyancy in the sac. Okay, without the amniotic fluid, that wouldn't happen. And so there, it would maybe could not grow in that kind of condition. And then lastly, it acts like amniotic fluid acts as a cushion to protect the fetus and the umbilical cord from injury. Yeah, I mean, you got to protect the fetus so he can keep growing, and the cord, has to be protected. And around the cord, there's a gel. It's called a Wharton's gel, and that protects the cord also, because again, that cord is in water also. So around this fetus, not only have this amniotic sac that is doing the work, okay, protecting the baby. The baby inside has this Vernix caseosa, which is, I call it nature's cold cream, because it's really thick, sticky white cream, but it protects the fetus, okay, while it's inside this fluid. And then you have Langugo. Those are little tiny hairs, and you'll see it'll be all really little hairs all over here. Again, it's protecting the fetus as he grows. Remember, fetal development goes from week 9 all the way to birth. Okay. So just to recap the stages of prenatal development. So prenatal development would be remember your little zygote? The zygote is a cell that's formed by the sperm and ovum come together. Okay, so you got a little zygote. Then he moves and makes his way, changes under cell division, makes his way through the fallopian tube into the uterus. Okay, when he gets into the uterus, he's a blastocyst, and then he implants in the endometrium, which is the inner lining of the uterus. Okay, and then he's there, and he burrows down into the endometrium, and he keeps cell division, and he develops into an embryo. Now, the embryo definitely has some big milestones as he develops, and that's from the 2nd to 8th week of development. And this is the time that most women don't realize that they're pregnant, okay? Sometimes after you miss one period, you go, okay, I missed one period. All right, but by the time the 8th week comes up, then you're thinking about to get a pregnancy test, okay? But you just missed an opportunity, a window of opportunity for the embryonic time, okay? And so hopefully she was eating properly and maybe taking a vitamin and taking care of herself so we can have good embryonic development, because that's important time. And that's when the neural tube in the fetus and the embryo actually closes. And so during the embryonic milestone, and so you want to make sure that she's taking some folic acid, because folic acid has been shown to decrease the possibility of her having an open neural tube defects such as spina bifida or hydrocephalus. Okay, so they have their milestones. They're very important during the embryonic time. Now the fetus is the 9th week until birth. And then, and we just went over that. And then we have what we call a term here. It's called the age of viability. And this is like a term that we use to determine, is the baby viable? Okay, and viability means, this is what it means. It means the ability of that fetus to be able to survive outside of mom's womb. Okay, outside of her uterus. So if she delivers, say, at 22 weeks, for instance, the baby has a fighting chance to survive. Now, it'll be in the neonatal intensive care unit until it gets to be, term. But at least 20 weeks is our term that we use to determine that the baby, excuse me, the fetus is able to live outside of mom's womb. So we use the age of viability of 20 weeks. So for instance, I work in labor and delivery, and so I'm on triage, and I get a phone call from the emergency department. And they said, I got a lady down here that's bleeding. So I said, okay, how many weeks gestation is she? And she tells me she's 17 weeks. Well, I know that viability is 20 weeks. So I'm saying to her, 17 weeks, that's really early, and that we really can't do anything for her in labor and delivery. So keep her in the ED. She's going to pass the fetus. So it's better that she be there than up in the labor room. So that's how we determine who comes up to the labor room and who doesn't. Okay, any questions about anything so far? Okay. So here I put in, it just shows you when the fetal stage begins, and I told you 9 weeks. And see, at 12 weeks, you start getting some sex organ differentiate. And then at 16 weeks, his little fingers and toes develop. 20 weeks is the age of viability. The hearing begins. He's tiny, but at 20 weeks, he's able to live outside of mom's womb. And then 24 weeks, the lungs are just beginning to develop, okay? So this is when they start to produce surfactant in the lungs, which is what he needs to be able to use his lungs at birth. And then 28 weeks, the brain grows, okay? And we have had the latest research is that the brain continues to grow until term, okay? Now, 32 weeks, the bones are fully developed. 36-week muscles are fully developed. And at 40 weeks now, he's considered to be a full-term baby. Now, here's our placenta. And the placenta is so important. This is a beautiful placenta, by the way. So this side here, which is the shiny side, is the neonate side, the newborn. We call that the Schultz, SCHULTZ, shiny Schultz. It's nice and shiny. And here's your cord going right through the middle, all right? This is the baby's lifeline, okay? The placenta is attached to mom's endometrium, okay? And that's where everything gets transferred from mommy to the placenta to baby. And the baby gets the blood and carrying oxygen through the cord to him. The other side is called the dirty Duncan, or the Duncan, which is the maternal, that's mommy's side. And that's the one that side is attached to her endometrium. So it would look more globule looking, it like have some different lobes to it because it's attached to her. And it's after she gives birth, during this third stage of labor, the placenta comes off the endometrium. Okay. And the placenta is really the organ for fetal respiration, nutrition, and excretion, like I just said. And the placenta has it has hormones, secretes progesterone, which you need to maintain a pregnancy, estrogen, which you need to stimulate uterine growth. And you have your HCG, your human chorionic gonadotrophin, and that can be picked up very early in pregnancy to let the woman know that, heads up, got a pregnancy here. And then you have your human placental glycogen, or HPL, which again is used for sugar, because the baby needs some sugar in order to grow. Okay. So here I outlined all what I just said on estrogen. So write down estrogen and put a dash, stimulates uterine growth. That's what it does. So estrogen, E extra, think of that way, increases the blood flow to the uterine vessels. It stimulates development of the breast ducts to prepare for breastfeeding or lactation. Okay, so estrogen is necessary. It really does. It's needed. These hormones, estrogen, progesterone, HCG, and HPL, are very, very important hormones, and they're all put out by the placenta. So the effects of estrogen, which are not related, it could be increased skin pigmentation, some vascular changes in the skin and mucous membranes of the nose and mouth, and increased saliva. Now let's write down progesterone. And progesterone has really a lot of functions. It's very important to maintain a pregnancy. So how it functions, it maintains the uterine lining for implantation of the zygote. I mean, that's important. Okay, so it maintains that uterine lining. So, you need that to maintain a pregnancy. Okay. Then it reduces uterine contractions to prevent spontaneous abortion, because if she starts to contract, she could miscarriage. Okay. And so, you want to have enough progesterone in your body to reduce this. You need progesterone to prepare the glands of the breast for lactation. Just like estrogen is necessary, so is progesterone. And then progesterone stimulates the testes to produce the testosterone, which is the male hormone, which aids the male fetus in developing the reproductive tract. So a lot of times, for instance, if you have a patient that had recurrent abortions, and so you want to really know that. That's why that obstetrical history is so important. It gives you a heads up. It's because she's lacking progesterone. So a lot of times what they do when they see recurrent, or we call it recurrent abortions, we do a blood test, and we'll do a hormonal level to see how much progesterone. And sure enough, it shows up that she has a low amount. And that's why they have all the time, they come up, they have these recurrent abortions. What we can do to help her is give her injections of progesterone. And that does work. Okay. Now your HPL is your human placental glycogen. Just like I said, what happens is it decreases the insulin sensitivity and utilization of glucose by the mom, and helps to make more glucose available to the fetus, because the fetus needs that to meet the growth needs. Okay. Now, when we talk about placenta, we talk about placenta transfer. All right. So in the umbilical cord, you have 3 vessels. You have 2 arteries and 1 vein. All right. And the reason why you have 2 arteries is because the arteries are the ones that are taking the blood and waste products that leave the fetus. They're taking them away. Okay. So you think it's opposite of normal circulation. All right. And so fetal deoxygenated blood and waste products, they leave the fetus through the umbilical arteries, the 2 arteries. Okay. All right. And then fetal and maternal blood normally do not mix. We don't like them to mix. And then oxygenated, nutrient-rich blood from mom is dispersed into those intravilli spaces from the spiral arteries in the decidua, which is the endometrium. Okay, so it's all kind of connected. And then you have fetal blood that releases the carbon dioxide waste products. So what these things, again, fetal deoxygenated blood and waste products leaves the fetus through the 2 arteries. Okay. So here is a really good little picture of placenta transfer. And don't forget, everything that mom takes in gets goes transplacental to the fetus. So if mom's smoking, the nicotine, all that will go to the fetus. Mom's drinking alcohol, go to the fetus. So remember this. Put AVA down, AVA, okay? That helps you. And that's artery, vein, artery. So 2 arteries and 1 vein. Okay, so to recap here, fetal blood takes oxygen and nutrients before returning to fetus through the umbilical vein, okay? So fetal blood takes your oxygen and nutrients through the vein, and everything gets what? Transferred out through the arteries. All right. So many harmful substances, like I said, can be transferred to the fetus. Even, infections, can be transferred to the fetus. Again, I guess I want to make sure you all have this. You have AVA, arteries, vein, artery. 2 arteries carry blood away from the fetus, okay? And 1 vein returns blood to the fetus. Okay. Now, you remember I told you about the Fortune's jelly that covers the protects the cord, because you got to protect the cord in that amniotic fluid. Okay, by protecting the cord, you are cushioning the cord vessels, the arteries and the vein. Okay, this is a really picture of a nice cord here. You can see it's nice and thick. That was a healthy mom. Okay, her cord looks so nice. When you have a smoker, let me tell you, this cord has like a yellow film right over it. And you can see when it comes out. And the placenta that you saw that was really healthy looking, if you're smoking, that also has like a film over it. And usually the placenta is smaller in a smoker. Because we have the opposite circulation, blood circulating in the uterus, we have fetal circulatory shunts. Okay, so these are there because it is to keep the blood from circulating normally. All right, so that the baby can get what it needs through the vein. Okay, oxygenation through the vein, and then carries deoxygenated and waste products through the arteries. So you have a couple what we call shunts, and you have the foramen ovale, which is like the opening. Let me see, it's the opening in the heart. It's right in here, the foramen ovale, and so it's an opening between the left and right atrium, which is your upper portion of the heart. Then you have the ductus arteriosus, which is a fetal artery that connects the aorta, which is your main stem, and the main lung artery. Because don't forget, babies don't breathe in utero like normally, like when we do, okay? So the lungs don't need a lot during the time he's in utero. And then the ductus venosus is a shunt that allows oxygenated blood to the umbilical vein to bypass the liver. And it's essential for normal fetal circulation. So this gives you an idea of what's happening. Test questions good at this level would be, about the arteries and the vein, and which one carries fetal deoxygenated blood and nutrient and waste products, and which one carries blood to the fetus. Okay. So again, this is the circulation before birth. The blood enters the fetal body through the umbilical vein, and a half goes through the liver, and then remaining enters into his heart, his inferior vena cava, and it goes through that shunt we talked about, ductus venosus, and then goes through the foramen ovale and the ductus arteriosus. Okay, and remember the foramen ovale is the shunt between the right and left atrium. And then you have blood containing waste products is returned back to the placenta through the umbilical arteries. Okay, all right. And then we're born. So now we have circulation after born. So, that first cry that we hear, and we like to hear that because that helps to close some of these shunts, because the foramen ovale closes within 2 hours after birth. And then it does close, of course, permanently by age 3 months. And then your ductus arteriosus, it closes within 15 hours. okay, and permanently about 3 weeks. And then the ductus venosus, it closes functionally when the cord is cut. That's when we say, this is very important because we say when the cord is cut, okay, baby, you're on your own. Start breathing. And when we hear that baby cry, that's like music to our ears. Okay. And then, all these little shunts that were in there, when everything closes up permanently and there's no need for them, they become like ligaments. So everything is utilized very well in the body. All righty. So when we have impaired prenatal development, that means that maybe mom's not taking in what she needs to, that will affect the baby. So we always said a healthy mom equals a healthy baby. So when we see like an IUGR baby, an intrauterine growth restricted baby, it's because they have a number of cells in the organs. It's because during the time they were being developed, mom was maybe drinking, taking alcohol, smoking, and so it affects the fetus. All right. So fetal growth is best assessed when the weight, length of gestation, okay, so the weight of the baby, the length, how many weeks it is, the placenta size, when we talked about the placenta, and the newborn head and his little abdomen, they're all considered, okay, when we determine how this baby grew inside. Hopefully mom did her best and she ate well, during pregnancy, but now a lot of times that doesn't always happen. And so the fetal growth could be diminished because there was limited nutrients and oxygen that's actually received from the mom. Remember, goes to baby through the placenta, right? Goes to baby through the placenta, and then baby grows, okay? And baby doesn't have a good environment, he doesn't grow right. All right. Again, mom being undernourished, and baby being undernourished in utero can result in permanent changes in fetal structure. And actually his fetus physiologically, metabolism. And then these children actually can grow into chronic conditions later in life. So I always say to prevent illnesses of the next generation, this generation must focus on their own health practices. And that's what we do when we get a new patient, newly pregnant, she comes into your prenatal clinic, is that we're going to focus on her health practices because we want to make sure that she gives the baby what the baby needs to grow. Twins. So I just want to go over this real quick with you. Twins, a monozygotic, we know about the zygote, we know about what that is, and the mono means one. So these are twins, monozygotic twins. They're formed from a single, remember those ovums? Okay, a single fertilized ovum, okay? And so you have identical twins, yeah, because there's only one fertilized ovum and then they split off. And then you have the other twins is called dizotic. So that means two. So that would be formed from two separate fertilized ovules. Okay, there's two of them. All right, I'm going to skip over this. It's like a little film on ovulation. And I'm going to go into chapter 4. So now she's going to come in for her prenatal care. Okay, so now we went over what happens in a girl's body and in a young man's body. Then we went over how fertilization occurs and where implantation occurs. So now, and the hormones. So she comes in and she thinks she's pregnant, and so now you're going to start some prenatal care, okay? And again, we want to focus on her health at this time because that's what we need to, right? We need to keep mom healthy, all right? Okay, because when mom's healthy, then we get a fetus is healthy. All right. This is how pregnancy is kind of divided. We have some phases of pregnancy. So we have antepartum, which is before birth. And then you have intrapartum during birth. And you have postpartum, which is after birth. So postpartum could be like 1 to 2 hours in the recovery room. And then she goes to mother baby unit. That's still postpartum. And then she goes home. And for 6 weeks, that's considered the 6-week period is considered postpartum, and then she goes back to her obstetrician for her 6-week postpartum check. And that's when we go over contraception, we go over how she's feeling, and then we release her, and she no longer needs an OB doctor. Okay, so what do you think our major goals of prenatal care is? Okay, well, we want to safe birth for mom and baby. So we're going to promote good health. Like I said, we want to always reduce risk factors, okay? Because we want this fetus, because we know how the fetus is growing. So, and we know that during the fetal development time is so important that mom eats right. So we want to teach her good health habits. And sometimes, she gets used to eating a certain way, and she says, oh, I can continue this even after pregnancy, which is a good thing. We educate moms in self-care, take care of thyself, and we provide physical care and prepare parents for the responsibilities of parenthood. That's all part of prenatal care, okay? Because we have to develop like a partnership with parents and the family, and to have good continuous and coordinate all the health care. So these are our major goals. So I always said healthy moms equal healthy babies, and everybody wants a Gerber baby. No, big old fat baby, healthy. Okay. Some terms related to pregnancy. Well, I mean, it's like your gravida, okay? And gravida, what? Gravida is means pregnancy, right? How many pregnancies she's had, all right? So it's the number of times that she's been pregnant, regardless of the outcome, okay? It's the number of times she's been pregnant, regardless of the outcome. And then para, because that's how we determine, especially when we do the obstetrical history. So we have gravida, and then we have para. And para refers to the number of pregnancies that have reached 20 weeks. Remember, 20 weeks is your viability time. And so gravida means the number of times they have been pregnant, regardless of the outcome. And para, P-A-R-A, refers to the number of pregnancies that have reached 20 weeks. Okay. So if you have a prima gravida, that's first time pregnant. And no gravida means she's never been pregnant. And a multi-gravida means she's been pregnant for at least a second time. Okay. All righty. Let's go on here. So we do an obstetrical history. So that prenatal care, they come in, you're going to do a medical history or surgical history on her. And this is where you find everything out about your patient. And we're going to do an obstetrical history, and that includes GTPAL, gravida term. Okay, you have a question?
I gotta go to class. My class starts
Okay.
at 3.
All righty. Thank you. Bye.
Thank you. Bye.
You're welcome. Okay, so gravida term, premature abortion and living. So gravida means, again, refers to the number of times one has been pregnant, regardless of the outcome. Term means that she made it to term. How many babies have made it to 37 weeks and above? Okay. Premature is from age of viability, which is 20 weeks, up to 36 6/7. All right. Okay. And then you have your abortions or your miscarriages. All right. And that's a pregnancy loss before 20 weeks. Okay. And that's counted as an abortion. And it adds to the client's gravity, but not gravity, which is this one, but not her para. Okay. Because that occurred before 20 weeks. All right. And then you have living, L for living. That's the number of children that are living. Okay. Now, if you have twins, the twins is one pregnancy. So it'd affect the gravida by just one. But where she gets credit is in the living. So they would consider then she had 2 living children. Okay. So again, this is a slide that just tells you, also in your HESI book, you have a good explanation in your HESI book. I think it's page 220, and it goes over this very, very well. Okay. But you have to know, like a good, and there's always a test question on Gravida and Para, or GTPAL. They may go for the 5-digit or the two-digit obstetrical history. The two-digit obstetrical history is Gravida and Para. Okay, all righty. So term, again, is 37 weeks to 40 weeks. And then premature would be anywhere from, say, greater than 20 weeks to 36 and 6/7. And then if we have your abortions, which are babies before 20 weeks, and your miscarriages, and you have your live births. So it's good to know that. All right, so I'm going to skip over this and go into our trimesters. And trimesters, so there's 3 trimesters, right? There's 3, and each trimester consists of 13 weeks. Okay, so that's how pregnancy is divided into 3 13-week parts. So it's important to know what occurs in each trimester, and in your book you have a really good table on that. It shows you exactly what occurs in each trimester, and what it does, it helps provide some guidance that we can anticipate giving to help her, and then we can identify deviations from the expected pattern of development. So like in the first trimester, you have a woman who's just been told she's pregnant, so she may have some ambivalence, which is common. It's kind of a shock sometimes to find out you're pregnant. And then they have to go through the changes or adapting what happens to her body during that time. And she could be having some nausea, vomiting during this time because of hormonal changes. So remember, estrogen and progesterone has been really increasing. And so she could have some nausea, vomiting. Okay, and they get through that first 13 weeks and they get into the second trimester, and that's kind of named or nicknamed the honeymoon stage. And the honeymoon stage is because she's feeling better. She's accepted the pregnancy. She may be feeling the baby move, but maybe she had a little quickening. She felt the baby move, and so now she can associate with the baby. It's kind of a nice stage. Okay. And then, maybe we have to look at, maybe do a glucose screening during that second trimester. And then the third trimester, I guess now she's being uncomfortable. Maybe her back hurts more because the growing uterus is in the front and it's growing. It's putting a lot of pressure. Remember I talked about the ligaments? And so that kind of, comes into play. Okay, so she could be more uncomfortable, and she can't wear her high heels anymore. She has to wear flat shoes because her center of gravity could be. So things like that happen. Usually in the last trimester, I have patients tell me, I'm done. Let's get this baby out. But we wait, okay? Because remember I told you the brain is growing all the way through term. And so even at term, baby's brain is still developing. All right, so part of prenatal care is the preconception care, and this is lovely. We can identify risk factors that can change before conception even occurs. It reduces the negative impact on the outcome of the pregnancy. Good deal. Yeah, we can get her on some folic acid even before she gets pregnant. Be lovely. Get her on vitamins. Then during that embryonic, remember I talk about the embryonic milestones. She's taken in what she needs to, which would be lovely because that would help prevent the neural tube defects in the developing fetus by giving her adequate intake of folic acid. Be great. And again, go over good nutrition. Everybody is, a lot of people, they don't eat right. And so we got to sit down and talk about nutrition. And then, of course, immunizations. We're going to test maybe about rubella. Rubella is a big one. And a lot of young ladies don't know, am I immune to it? Did I have a shot? You know, the measles, mumps, rubella shot. So because rubella is a severe teratogen to the growing fetus. So we want to make sure that she is immune. Okay. So it'd be kind of nice. So what's your role? You're going to collect your data. Okay. So you're going to sit down in a nice room and collect the data with the patient. So you'll do, again, her medical history, a surgical history, and a obstetrical history. And we're going to identify and reevaluate some risk factors. Maybe she's coming in and she's has hypertension already. Maybe she's on some antihypertensive medicines. Maybe she's a diabetic. So this is where we're going to identify and go over and reevaluate these risk factors, because during pregnancy, everything kind of escalates. And I'm going to even know if is she bipolar, she have any kind of problems with depression. Need to know that at that time. And then, of course, educating. I'm going to educate her in self-care, like we talked about earlier, you know, so she takes care of herself. If she takes care of herself, the baby will be effective, be better for the baby. And then, of course, here again, nutrition. Okay, especially I'm thinking of the adolescent group. Okay, that'd be good to have with a dietitian at least once to go over proper nutrition, because the adolescence has a tendency not to eat like they're supposed to, you know. They like a lot of French fries, maybe potato chips, things like that. So go over some good counseling with them. And then again, promoting family adaptation to pregnancy. The family is going to change considerably when now there's going to be a baby in the family. So these are our recommended schedule of prenatal visits. Now, this is an uncomplicated pregnancy, so it's not a high-risk pregnancy, so just regular, normal pregnancy. So you go from conception to 28 weeks, you go to the obstetrician every 4 weeks. Okay. Then by 29 weeks to 36 weeks is every 2 to 3 weeks. And then at 37 weeks to birth, she comes in weekly. Yeah, so this is when your advanced maternal age patients, the ones that are over 35, they kind of say, I can come in weekly. Yes, because, you know, they're business people and they're busy and they don't want to be bothered, but you have to monitor them and make sure, because that's the time that things can really change also, and like blood pressure and maybe baby not moving, and we want to keep on top of everything. Okay. So again, our antepartum nursing care, obstetrical history, we have the two common methods, the gravida and the para, or the 5-digit, where we can really know what's going on. We know how many pregnancies she's had, how many of those pregnancies reached term, how many of those pregnancies were premature babies. Did she have any abortion or miscarriages in this time? And then how many living children she has. This really tells you a lot. And then after that, we refer to her gravida and para. Okay. Alrighty. Then here, we're going to assist with the physical exam. Okay, so this will be your role in when she comes in. And then you're going to calculate her gestational age. So how many weeks pregnant is she? And you can do that by using the Nagel's rule. Remember Nagel's rule? There's always a question on every test on Nagel's rule. So you're going to take her first day of her last normal menstrual period, the first day, and you're going to count back 3 months, okay, and add 7 days to that first day of the last normal period, okay? And then, of course, you'll adjust the year if you need to, but that is how you use the Nagel's rule, okay? Ultrasounds. Now, this is a uncomplicated pregnancy, so we usually 2 ultrasounds, and there's usually one around 10 weeks gestation. And we do the 10 weeks because we can see then the fetus and we can see the heart, okay? Because one of the complications is if she comes in and we don't see that heart beating, then we could have a molar pregnancy. And so we want to see that 10-week ultrasound. And that is your positive sign of pregnancy, by the way, is your 10-week ultrasound. And also we wanted to do that 10-week because we can get a great measurement of the fetus, okay? Because here's, we can do what we call a crown rump. So the top of his head to his, to the bottom of the fetus, that's the rump. And so we can get that measurement, take that measurement, and then see how many weeks she is. And then by that, we can determine her EDC. I mean, that's really a good way. Okay. And then we're also going to obtain her vital signs. You want to get a baseline, blood pressure, pulse. You want to, respirations and her temperature, make sure everything's okay. And you always want to get a baseline because during pregnancy, blood pressure has a tendency to increase. The pulse has has a tendency to increase because of the increased cardiac output. And so, and then of course her, we want to make sure she's breathing okay and she's got an average, respiration rate, which is about 16 to 24 breaths per minute. You want to have that so that if anything changes during the pregnancy, you can pick them up real quick. So that's your nursing care, and it's very important. Now, during that first visit, you're going to send her for blood work. And we get quite a bit, usually get about 5 tubes of blood work. So we're going to get an HIV testing, CBC, complete blood count. Here's your rubella titer, got to find out if she's immune or not. Hepatitis B, RPR, or I'm checking for syphilis. VDRL, I'm checking again for venereal diseases. RH and blood type. Yeah, I want to know what her RH factor is because if she's negative, remember negative, she needs to have RhoGAM during the pregnancy and then after she delivers, and then do a pap smear, make sure there's nothing growing on that cervix, and then vaginal cultures. I'm looking for gonorrhea and chlamydia because those are things that can harm the fetus. And then if you have a history of sickle cell, I'm going to do a hemoglobin electrophoresis. And then, of course, I'll do a urinalysis. One, I'll test again for presence of HCG and then presence of any kind of nitrites or WBCs, because I don't want her to get a UTI. Remember, the bladder lays underneath the uterus, and that bladder gets inflamed. It makes the uterus start to contract, okay? The uterus starts to contract and she could lose a pregnancy. So we don't want that to happen. And then we want to get a good H&H on her again by doing a CBC to help evaluate what she's been eating. Is she anemic? Do I need to give her iron from the very beginning? Or do I need to just help her eat foods that are good, recommended foods that are high in iron? So again, what you're doing at each every time she comes in, you're always looking ahead for these risk factors. I'm always checking the blood pressure. I'm getting a weight. Okay. Okay. I'm always comparing it to my baseline blood pressure. Okay. I'm getting a urinalysis. She gives me a little cup of urine. I'm going to test it by using a, multi-stick. And I can check it and it can show me if I have protein in the urine, if I got glucose, ketones, and albumin. It's really good. It's a little dipstick and it can tell me a lot. And this is all very important because protein, she starts spilling protein after 20 weeks and her blood pressure is going up. I may have the start of that complication preeclampsia. Okay. If she's spilling glucose in the urine, okay, by the time you spill anything in the urine, you got a good amount circulating. If she's spilling glucose in the urine, maybe I need to screen for gestational diabetes a little earlier. Okay, so that gives me a clue. So again, these are things that I look for. And then of course on my blood work, I'm going to monitor for anemia because remember I got the baseline blood work, right? And I can see what's going on. A lot of times we'll do a little finger stick on that and we'll just do a maybe hematocrit level. And then her fundal height, every time she comes in, we're gonna measure her belly and see. That fundal height does give us a lot of clues. It gives me a clue if the fetus is growing properly or my amniotic fluid volume is okay. And if these things don't match up, then I'm going to have to maybe refer her for another ultrasound. See how we can pick things up by just doing a simple measurement. And then, lever pulse maneuver is where you put your hands on her belly and you can assess, is it what's presenting, what kind of position is baby in? Is baby in maybe a breech or a transverse lie? So, these are things that you can do, and it's simple. I'm going to use a Doppler and listen to fetal heart sounds. I want to hear that beautiful beep, 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 beep. And normal fetal heart rates between 110 to 160 beats per minute. Nutrition, especially in the third trimester, because the third trimester is where there's rapid growth of the fetus. Okay, so I'm gonna be checking her for that. And of course, any new discomforts or problems, and usually the third trimester, I got some ligament pain. That's because the uterus puts so much pressure on all the different ligaments, and they have a bunch of nerve endings, and that will be very discerning to the mom. It causes pain. So again, I'm going to make sure she's doing what she needs to. She's getting at least increase about 300 calories, okay, during pregnancy, okay. She gets an extra 500 calories, she breastfeeds, okay, but 300 calories extra during pregnancy, and you should have good amount of protein, at least by 30 grams per day, increase intake of iron and folic acid through a diet or supplements, and then usually they take a nice, good vitamin, and those vitamins have your vitamin A, vitamin C, get the calcium through the diet. Is she tolerating the milk products? Okay, getting some calcium. And then she drinking at least 8 to 10 glasses of fluid per day. Okay, and the best is to get like 4 to 6 glasses of water. Keep, fluctuating. Make sure by drinking water too, she keeps her body hydrated, and you want to keep the muscle of the uterus hydrated so it doesn't start to contract. All right. Now this just goes over the Naegele's rule. So again, your average pregnancy lasts 40 weeks. Okay, that's 280 days after the first day of the last normal menstrual period. And usually you're probably normal, you're probably seeing LMP, but we put that in there because not everybody's cycles are normal. So last normal menstrual period. And of course, we do a plus or minus 2 weeks, but Naegele's rule. So here you do. So you're going to identify the first day. And here I'm saying first day, okay? Okay, of your last normal menstrual period. Then you count back 3 months, okay? And then you add 7 days to that first day. All right. Okay. Now, diagnosing a pregnancy. So again, we have 3 groups, okay? So we have these are signs of pregnancy. And so we have the presumptive sign, you have the probable sign, and you have the positive sign. Okay, so we have 3 little groups. Okay, so remember something, presumptive, okay, presumptive has that you in it, right? So think of you, think of the woman, you. All right, so I can come in and say, well, I haven't had my period, I'm feeling a little nausea, it's got some breast tenderness, right? But that's not positive because the woman is feeling it, she's feeling it, okay? And yeah, amenorrhea, well, I haven't had my period, so you think I'm pregnant, but it could be that something else is going on. I could be under a lot of stress that maybe throw my cycles off. So you have to, it's not positive. All right, but again, the woman is feeling it, you, all right? Now, probable signs of pregnancy is what the examiner actually sees. Probable. So he or she will take like the speculum and look up the vagina and look and visualize the cervix. If he sees like a bluish, purplish change in the cervix, that's the Chadwick sign. Again, there's different things that are happening. The examiner is seeing that. So that's a Chadwick sign. And then you have the McDonald sign and the Hager sign, these are all different signs of pregnancy, but the examiner is seeing those. And then a positive sign. The positive sign is that ultrasound. Okay, that ultrasound, that when you see it, there's a fetus there. All right, and you see the little heartbeat, boom, 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 and you can hear it. And so, and maybe there's some fetal movement that's actually felt by the examiner. So that's a positive sign. Now, a good test question could be, a positive sign of pregnancy is, and it would be, you have A, B, C, D, a choice. And so then you would put like a choice of ultrasound would be on there. The same thing with presumptive and probable. So again, positive is pretty positive when you see an ultrasound. Okay. Okay. That's pretty positive. You can't debate that. A probable sign is one that the examiner sees. Okay. So as an examiner, I'm looking up and seeing the cervix, and I see that Chadwick sign, which is the bluish purplish congestion of the cervix. And then presumptive is what the woman feels. Okay, so again, remember the you in presumptive, what the woman feels, what you feel. All right, so those are the different signs of pregnancy. So I went in a little bit more detail here. So again, see the big U, okay. And so these are things that happen, but it's happening to the woman, okay. This is probable signs of pregnancy I just talked about, okay. You have the Chadwick sign, which is the big one, purplish bluish discoloration of the cervix. You have the Goodell sign, which is softening of the cervix. So the probable, again, what I'm getting at is evidenced by the examiner, okay. The positive is your ultrasound. There we go. Here's our fetus. That's pretty positive. You're to tell the woman, yes, you are pregnant. Okay. All right. I added another slide in here only to go over this again to help you. All right. So let's go over some normal changes. These are physiological changes that occur in pregnancy. So her whole body, a woman's body is affected. Okay, the endocrine system has the most significant change. All right, because the placenta itself is a temporary endocrine organ, and it produces a large amount of estrogen and progesterone to maintain the pregnancy. So we talked about that. So now the next part of her is her reproductive, right? So now, remember she had that pear-shaped organ, that's the uterus. And now the uterus is going to grow, and it's going to come out of the pelvis, and it's going to come up, when you get about 40 weeks gestation, it comes up to like her xiphoid process. Okay. It gets big. It can house about 5,000 mLs with the placenta, the fetus, the amniotic fluid. All right. All that plays. So here now her uterus is grown, and now she's it's pushing against her diaphragm and her lungs. And so what happens is that, it's harder to breathe. And so her O2 consumption does increase by 15%. And, she may not be able to walk up the stairs like she could. The cardiovascular system increases. You have an increase of cardiac output 45 to 50%. So a lot of blood is being pumped from the heart. So it puts a little strain on the heart, and her pulse rate can go up at least 10 to 15 beats per minute. The GI, so the tract changes a little bit because of the hormones, and also because the growing uterus. It displaces the stomach and her intestines, and actually pushes like toward the back. So therefore, she gets more heartburn, and she can't eat large meals anymore. So I usually tell my patients to eat small, frequent meals, so she doesn't get hypoglycemic. And so, but she's got to eat, okay? And then urinary, don't forget, she's actually screening waste products for both of them, for both her and the fetus during pregnancy. So she's going to go more often. And then the skin and the skeleton, the skin stretches. But when you gain a lot of weight very quickly, you get these striae gravidarum, which are stretch marks, okay? And so they never go away because skin and out has been overly stressed out, okay? And so, but by putting cream on your abdomen and not gaining a lot of weight suddenly will help that. And safety, you have to teach her, her center of gravity is going to change, her balance is going to change. That's why I tell them, be careful going in and out of a bathtub. Okay. I always tell them, wear low flash shoes, no longer high heels, because they can fall. And when a woman, has any trauma to her abdomen, what happens is she can, the placenta can come right off the endometrium and be abrupting. So you don't want that to happen. So I just tell them to be very careful, not to fall and not to, protect her belly. Okay. All right. So again, these are all different effects of the pregnancy on the endocrine system. There's going to be dramatic increases in hormones. You got the placenta, and that's a temporary endocrine organ. And the primary role is to keep that estrogen and progesterone. Okay. They keep producing that because you need that in pregnancy. All righty, let's see here. We talked about progesterone needed to maintain what we call the decidua, which is the endometrium lining. Okay. All right. There's another interesting phenomenon that happens is the mucus plug, and that where that comes in is kind of like right in the neck of the uterus, right by the cervix there, and so that protects from any bugs like ascending going up into the uterus. Okay, so it's a mucus plug. It's really mucusy. And we talked about the height of the fundus during gestation. Here you are. Here's a picture of an obstetrician measuring fundal height. So what happens is that weeks gestation should correlate with the centimeters of the fundus here. The measurement. So for instance, she's 26 weeks gestation. She should measure 26 centimeters. If she measures under, the baby could be smaller. Okay, so the baby's not growing. Well, why is this baby growing? So then we have to start looking for reasons why this baby's not growing. Or she could have less amniotic fluid, and that would be an indication that the baby's kidneys are not producing urine. So we want this simple little measurement really does help. Okay, and this is a great picture that comes right out of your textbook, and it shows you how the uterus grows, and it comes out of the pelvis, and then it becomes into right here, it comes into the abdominal organ. Okay. All right, and we talked about already, oxygen consumption increases by 15%. And again, increase, she could have a little bit of difficulty in breathing. Because the uterus is growing up, as I told you, about 40 weeks, it's up by your xiphoid process, so it could put a lot of pressure. But when the baby gets engaged and drops, that's when you can feel better, and therefore, she can breathe a little bit easier. But increased estrogen, and this is a good test question. Increased estrogen causes like edema and swelling of the mucous membranes of the nose, the mouth, and trachea. And so, a lot of women will complain of stuffiness, stuffiness in the nose. And so that could be from estrogen. Remember, estrogen increases saliva, and that can happen too. Here's a picture of our beautiful heart. And again, cardiac output increases by 45 to 50%. And the reason why it has to really increase is because, don't forget, you have a placenta, and you have exchange of nutrients and oxygen and waste products, all happening within that placenta. So sure, that placenta is going to be very vascular. And then again, you have maternal tissue that expands. So you need more vascularity, more blood going to the tissue, because everything in the body requires oxygen. Okay. So therefore, blood transfers oxygen, so you need blood to transfer the oxygen to the body. Kind of makes sense. And then of course, when she delivers the baby, There's a lot of blood loss at birth. So, you know, she has to be able to compensate for that blood loss, and that's what happens too. All righty. And then just to know her pulse rate increases by 10 to 15 beats. Okay, because increase, you know, it does make sense. It's not that bad, that much of an increase, but enough to help with, you know, to handle the cardiac output. All righty. Let's talk about supine hypotension syndrome. So what I want to tell you is never lay a pregnant woman on her back, okay? She's gonna, if you put this woman on her back with this kind of belly here, pregnant belly, that puts a lot of pressure on her inferior vena cava, okay? And so when you do that, you're compressing and you're decreasing the amount of blood oxygen being circulated. So your patient is going to get feelings of like lightheadedness, fainty, dizzy. And if you don't get her off her back, she's going to get a little bit of agitation because she can't breathe, she can't function. And so then when you have a decrease to her heart, you're also decreasing it to the fetus. So then you can get some fetal problems, fetal heart rate would go down. So what are you going to do? Turn her to her side. Her left side is preferable because you get more placenta perfusion. All right, and she gets, what happens is you increase her, she can now breathe, she gets more blood flow, she gets more oxygen flow, and that gets transferred to the fetus through the placenta, and then the fetus will have a better heartbeat, okay, because he's getting more oxygen also. So whatever you do to mom affects the fetus. This is exactly what I was talking about. This is what it shows you. So here's her inferior vena cava. Here she's got this. Here you have the baby. Remember, this uterus can hold up to 5,000 mLs of fluid. So you got the fetus, you got fluid, and that's a lot of pressure. Okay, so that doesn't look very comfortable whatsoever. So that would decrease her blood flow and decrease her oxygenation. And then, you know, when she's in labor, and this is what happens when labor, because labor, one contraction is equal to 50 millimeters of mercury, which is very strong. And that would put a lot of pressure on her inferior vena cava. So the best thing to do is I always labor my patients on the side. Okay. Because I don't want her blood pressure to go down. You know, all these things can happen. She can get orthostatic hypotension, blood pressure goes down, get some palpitations, not good. Because the cardiovascular system is going through so much. Don't forget, she's got a blood volume going on, so you may have the pseudoanemia, what we call a dilution anemia. You know, you have increased clotting factors that are happening in the second and third trimester. So she's more prone for a DVT, a thrombophlebitis. So all these things come into play in the cardiovascular system. We talked about already the uterus and the stomach. I'm not gonna kind of go over that. And you can see here, you have a woman that has a small uterus, all right? You see her intestines, everything is laying very nicely, all right? Her liver's good. And now she's pregnant, she got a growing fetus in here. And you can see what's happening. And you see what's happening to her intestines. They're getting pushed up. And you can see here now she's getting closer to term. And you can see everything is more displaced. See the liver is even squished, and there's not that much room left. Okay, and so those are some things that you have to put up with when you're pregnant, and it's hard, you know. Women on the urinary system, there's you have increased blood volume, and you have things that, you know, coming from the fetus through the placenta, and mom has to get rid of it. So you have increase in the, you know, the glomerular filtration rate of the kidneys. Progesterone plays, you know, causes the renal pelvis in your uterus to lose tone. So, you know, she might not be able to hold her urine. And then again, it might be that because the decrease of tone, it leads to more urinary stasis. The urine is not being pushed out. and therefore now she's more prone to a urinary tract infection, which then can lead to preterm labor. And you have some fluid retention because 99% of sodium is reabsorbed, so that's why they can get some fluid retention. So again, going back to my one slide, I said try to get some water in her, at least 4 to 6 glasses of water a day, and keep drinking water. Now, weight gain for a normal height woman, this is a good test question, by the way. So normal height woman, the normal weight gain is like 25 to 35 pounds. Okay. And so that's a pretty good amount of weight. And so she doesn't get overweight. But if she starts out overweight, then she can only gain 11 to 25 pounds. And if she falls under the obese category, then she's only gonna have a weight from 11 to 15 pounds. Alrighty. There are some special nutrition considerations in pregnancy, and the big one is called PICA, P-I-C-A. This is where a woman has a craving for a non-food item. Now, it's normal, okay, for her to crave like chalk or like soil, okay, and as a nurse, we don't, judge, okay, because we know it's normal. These are special nutrition considerations, so we know it's normal. So what I have to ask my patient is, how much of that chalk are you eating? How much of that soil that you're eating? Because that's what I want to know as a nurse, okay? Because I know it happens. It doesn't happen to everybody, but certain cravings are there, and some women like other cravings, and that's okay. But PICA is a special consideration. We talked about the extra calories during pregnancy. We do have extra calories if we're breastfeeding or during lactation, and that's around 500 calories that she can have when she's breastfeeding. So 300 during the pregnancy and 500 if she's breastfeeding. Okay. We always try to limit the intake of caffeine and alcohol. Some women just can't. So maybe go down to decaffeinated, and maybe go from maybe 3 cups down to 1 cup, kind of wean down a little bit so they don't get terrible headaches. Okay. Exercise, focus exercise during pregnancy would be to maintain fitness. Okay. We're not going for weight loss. We're not going for any kind of improvement of fitness or anything. We just want to maintain. And a woman who walks about 30 minutes a day on just, basic walking, gets up and moves, really does help. They help a lot during the labor process. Traveling, you can travel up to 36 weeks pregnant, okay? It's usually deemed safe up to about 36 weeks. After 36 weeks, you want to stay home more, but up to 36 weeks should be okay. You always want to tell them, don't sit for a long time, avoid locations that maybe you're going to put you and the baby at risk for an infectious disease. Always take a copy of your obstetrical record. And then note, when you go some places where there's a hospital that can take care of you in case you go into like preterm labor. These are just a list of some common discomforts in pregnancy. We talk about fatigue, nasal stuffiness, estrogen, nausea, the heartburn, constipation, hemorrhoids. If you get hemorrhoids during pregnancy and during it's painful. It's very annoying. And then when you go into labor, they will get bigger as you push and put a lot of pressure. So you want to make sure that she avoids being constipated, maybe increase the fiber, increase water, get out and walk a little bit. That's what all will help constipation. Daddies go through a stage of development also. And so they have the 4 stages like announcement, acceptance, adjustment, and focus. And basically, they have to get used to being pregnant, and then they had to accept it, okay? And when they accept it, it really strengthens the family unit, and then they adjust their lifestyle, and then they focus, maybe do some active plans for, maybe they're going to participate in labor and birth. Okay. The adolescent goes through their own time, and it's pretty hard to be pregnant and when you're an adolescent, because adolescent is stealth. Remember, we talked about how young lady's body changes. And so she's got to cope with two of the life's most stress laden transitions at the same time, adolescence and parenthood. It's a tough time to adjust, and their basic needs on nutrition. Okay, they need a good nutrition counseling. They need a lot of support. They need to have good community resources and made available to them. And as a nurse, you're going to make those recommendations. The single mom also has unique emotional needs. Okay, she's going to have to prepare for pregnancy, financial and lifestyle changes. Not easy. And if she's, a mature lady, having a baby, who's going to take care of the baby while she has to return to work? Again, financial problems. And so they go through their own unique. Immunizations. Let me put it really simple. You don't give a live virus vaccine to anyone who's pregnant. Okay, a live virus vaccine to anyone who's pregnant. So like rubella. Rubella is considered a live virus, so we do not give it all during pregnancy. Write that down. Rubella, do not give during pregnancy. So what happens? She comes into you, and you do her blood work, and you find out, you do her rubella titer, and you find out she's not immune. Okay. So, but she's pregnant, so you cannot give her the vaccine. She goes through the pregnancy, delivers the baby, and you can give her rubella after she delivers. Okay. You can give her before she leaves the hospital. You give her rubella, and of course you tell her, don't get pregnant for 1 month, and hopefully during the postpartum period they're not going to get pregnant again. Okay, so then you gave it to her. Okay, the main thing is that you don't give it during pregnancy. So and if she comes to you preconception, yes, you can do the rubella titer. She's not immune. You talk to her. I'm going to give you the rubella vaccine, but you have to wait 1 month till you get pregnant again, because rubella is such a teratogen to the developing fetus that you don't want to put at risk. Okay. Now we're going to move into chapter 5, and this is the last chapter. So hang in there with me. This is nursing care of women with complications. So we already talked about a couple. We talked about ectopic pregnancy, and we talked about a little bit about preeclampsia. But these are some danger signs in pregnancy. So if you have like a sudden gush of fluid from the vagina, that means the bag of water has broken. That's a danger sign. Vaginal bleeding in the beginning of pregnancy could be that she's aborting the baby. She's having a miscarriage. So you want to jump in there and find out what's going on. Abdominal pain, she could be having an ectopic pregnancy because they usually have right lower quadrant pain. So you want to find out. Again, danger signs of pregnancy. Persistent vomiting could be due to maybe she's got hyperemesis gravidarum. She's got this persistent vomiting, which is not normal because hyperemesis gravidarum can lead to electrolyte imbalance. And so that's not good for her or the baby. Epigastric pain is a sign of preeclampsia. That means that the liver is enlarging. And so you want to hop in on that one. Again, a danger sign. And edema of the face and hands, that's a sign of a preeclampsia. Severe persistent headache, another sign of preeclampsia. Having problems with her vision. Either she's blurred vision or some spots before her eyes. Those are all really bad signs of preeclampsia. A fever, maybe 100.4 or greater. She could have chorioamnionitis. Remember the chorion and the amnion, how they develop, could have that. Okay. And of course, painful urination or reduced urine output. All right. So this here, okay. Hi, Jada, you need something?
No, I was just telling you that I have to go. I have to get ready for class.
Okay, have a good class, okay?
Are you gonna send this video to me?
Yes, what we're gonna do is I will, this will be posted under exam reviews,
Okay.
okay?
All
All
right,
righty,
thank
good
you.
luck with everything.
All right.
Bye-bye, nice to meet you.
Nice to meet you too.
Okay, so let me go with an amniocentesis. So an amniocentesis is the removal of amniotic fluid sample from the uterus. So here again, this is, remember, your chorionic villi. This is your spiral arteries, okay? Here's your placenta, okay? And here's the uterine wall, see? Okay. So what happens with an amniocentesis, we're going to go in with the spinal needle, very thin needle, and we're going to go into the amniotic sac, and we're going to take out some of the amniotic fluid, okay? And that we do for like a chromosomal analysis in the beginning of pregnancy to determine if the baby is okay, because you're looking at the chromosomes, all right? Now, if we do an amniocentesis later in pregnancy, maybe she's in and out of preterm labor, and we can do the amniocentesis. And what we're looking on that is actually the LS ratio to see if the baby's lungs are developed enough for the baby to be delivered. So again, there's two different reasons. One can be in the beginning of pregnancy and one can be in the end. But the main thing to know, guys, is that this is a very risky procedure, okay? You know, you have to be very careful. Say you're under ultrasound guidance here, as you can see, the ultrasound transducer. And you know, you have to be very careful that you don't puncture the baby, all right? Okay. Now, pregnancy related complications. So this is remember, this is the chapter on complications. So we're going to discuss about hyperemesis gravidarum, some bleeding disorders, hypertension, preeclampsia, eclampsia, and then blood incompatibility between the woman and the fetus. Now, in hyperemesis, this is going beyond just the nausea and vomiting of pregnancy, okay? This will go all the way to the end, okay? The whole entire time she's pregnant. So what you want to do is you've got to make sure she doesn't get dehydrated and the electrolyte imbalance. So you're going to give some antiemetic drugs. So, I mean, like Reglan or Zofran, if this is necessary. And she's in the hospital, has an IV, because you're hydrating her. You're gonna do some blood work to check out the electrolyte imbalance, and you're gonna give her some antiemetic drugs, Reglan and Zofran. It can impact the fetal growth, okay? And because the baby needs nourishment from mom, remember? And so baby doesn't get it when it needs, maybe has a decrease in HPL, the human placenta glycogen. So the fetus may not grow as well. And you want to avoid dehydration at all costs. Okay. Now, another bleeding disorder of early pregnancy would be your abortions, okay, or miscarriages. And so you may have what we call spontaneous, which means it's non-intentional. And it can be threatened and inevitable. You can't stop it. Incomplete, complete, missed, and recurrent. So here you have a threatened abortion, and let me make this a little bigger for you. You have vaginal bleeding that can occur. So she could have like some slight cramping, okay, and then have some vaginal bleeding coming out, all right? That's a threatened abortion. Now this one, and you can't stop it, it's gonna happen. So here, inevitable abortion is where you can see the membranes have ruptured and the cervix dilates. It's all open, okay? And again, you cannot stop this. It's got to happen no matter what you do. You can't do anything, okay? Because the bag of water is gone and the cervix is wide open. Here you can see the cervix not that much and the bag of water is intact. So it's good. Now this one here is called the incomplete abortion. This is where you have some products of conception that have been expelled, but you know, some are retained and remain in the uterus. All right, so that's incomplete. You know, so it's hard. And with a misabortion is that maybe you have the a fetus gets expelled, and so then you have the membranes that need to be cleaned out. All these have to be cleaned out by a D&C. So when you're looking at someone who is bleeding, okay, you want to document the amount and character of the bleeding. You want, you save anything that looks like a clotted tissue. Because I want to get evaluated by a pathologist, and you do your pad count, and you monitor her vital signs, and just in case if she is actively bleeding, you probably have to send her for a D&C. So she has to have a surgery, and D&C, they're under general anesthetic, so you don't want anything in her gut. So you're going to keep her NPO. We talked about this already earlier today when we talked about how the ovum and it turns into the zygote when it gets fertilized. It moves through the fallopian tube. And I said when they don't make it through the fallopian tube, you end up with a pregnancy inside that tube, and it's called ectopic. So it forms, other than where it should be going to, it stays in the fallopian tube. And what happens? It grows because it doesn't know to stop cell dividing. So you still have the process of meiotic process still going on. And so you have to get it out. Okay. So you have to act quickly because she's going to have lower abdominal pain. And they have a lot of pain. They'll call you on the phone, say you're doing triage, and the lady calls in and she's in a lot of abdominal pain. So I always ask where, and it's a lower abdominal pain. Of course, how's your pain? They usually say 10. It's awful. And I'll say, when was your last normal period? And they say, oh, I think maybe it was about 7 weeks ago. I don't know. And so anyway, I go, okay. I'm thinking, okay, she could have ectopic pregnancy. Okay. So what am I going to do? I'm going to get her to the hospital. Okay. Tell her to go directly to the ED and we're going to do an ultrasound, and sure enough, there it is in the tube. Okay. If we can do it fast enough, it's great because you save the tube. All right. If she waits and doesn't go directly to the ED like you told her to, and the pain will get more intense, and she can rupture her tube. So you don't want that to happen. So here's a nice little other sites for ectopic pregnancy. They can occur anywhere else, because as you can see, but about 95% occur in the fallopian tube. Okay, I told you, of course, there's a lot of pain. She may have some light bleeding, all right? But again, pain, abdominal pain. And if you don't get on top of things, she could go into hypovolemic shock. And a lot of times too, because the pain can radiate, and we call that referred pain, she can get shoulder pain. All right. Again, you want to get her quick enough that you can get her treatment with, if you get it, if you get the diagnosis of ectopic before it ruptures, you can treat it with a drug called methotrexate. And what that does, that inhibits the cell division, and then that little zygote will die off, and it'll get reabsorbed by the body. Or you may have to have surgery to remove the pregnancy from the tube, and she could lose her tube, but you don't want that to happen. So this is an important slide here about hypovolemic shock. Okay, again, low blood volume, and remember something. Every organ inside your body needs blood. Blood carries oxygen. So every organ needs blood. So you might have the first sign that you see something going wrong with your patient is she gets real tachycardic. Okay, so she could have a rising weak pulse. Okay, rising respiratory rate, we'll call tachypnea. Shallow, irregular respirations, we call that air hunger. Her blood pressure could go down, so you get hypotension, and you can have decrease or absence in the urinary output. Okay, these are not good, you know, these are very bad, again, because the kidney, the body is really good. The body says, say, okay, I'm not gonna send blood to the kidneys, okay? I'm gonna send all that extra blood now that would have gone to the kidneys, I'm gonna send it up to the heart, okay? So now your kidneys are not functioning like they should, you get that decrease in urinary output. And which we know we don't want it to go less than 30 mLs per hour. Otherwise, the kidneys shut down. And then, you know, somebody's losing a lot of blood, you basically the mucous membranes, you know, are real pale, the skin gets pale, and she gets cold and clammy and fainty, not good. All right, so this is about a pregnancy now. We're gonna move into the hydiniform mole, or is also known as gestational trophoblastic disease, okay? So what happens, it occurs when that, you remember that chorionic villi that normally, you know, will increase, you know, what happens is chorionic villi abnormally increases and develops these little vesicles, okay? And she could have, you know, hemorrhage, she could have some clotting abnormalities, hypertension, and later development of cancer. Not a good thing to happen. So what happens is that the embryo did not develop. So how you pick this up, because, you know, she's going to secrete HCG. It actually doubles, you know, HCG will go up with the pregnancy, and then it tapers off. But with the molar pregnancy, it just keeps going up, and it just multiplies tremendously. So they get high levels of HCG levels. And then the uterus, because it's just a cluster of cells and has no formal embryo or anything, there's no baby. So it makes the uterus look bigger than it should for the dates of gestation that the patient is at. So not a good thing. And women that are trying to get pregnant, when they come up and they go for that 10-week ultrasound, like I talked about earlier, and you look at the ultrasound and there's no heartbeat, that's when you know you got a molar pregnancy. All right, so what you see bleeding, rapid uterine growth, like I talked about. There's no fetal heart activity. And she could have signs of hyperemesis gravidarum. She has, persistent vomiting. I talked about higher than expected levels of HCG. And then it just sees, you see there's a whole bunch of, like, it looks like a snowstorm pattern on ultrasound of all just its cells, you know, that chorionic villi with just a bunch of cells, look like a bunch of grapes, but there's no evidence of a developing fetus, okay? What you got to do is you got to evacuate the uterus and probably do like a DNC. All right, so now that was a molar pregnancy. So now we're going to go into some bleeding disorders of late pregnancy. And we have two, placenta previa and abruptio placentae. So what I want you to know about placenta previa is the placenta is laying in a place it's not supposed to be. It's laying maybe right over the cervix, okay? And it shouldn't be there. It should be higher up in the endometrium. But it found its way, it moved, and now is over the cervix. So what happens is she's going to have bright red bleeding. And she's not in pain. So placenta previa is noted for painless, bright red bleeding, okay? So here's your placenta. So here you can see the baby, and you see the placenta here. It shouldn't be down here. It should be way up here. So the placenta is low-lying, and what happens, it does make her to have bright red, painless bleeding, okay? The other bleeding disorders of late pregnancy is when placenta will come right off that endometrium. And as you can see here, here is your placenta, and see how it came off the endometrium, all right? And here you can see where she's bleeding. This is a little a hemorrhage. This is an obstetrical emergency, okay? And how you know it, patient comes in and she's in a lot of pain, okay? A lot of pain. Her bleeding is dark red, okay? And her abdomen, when you feel her tummy, it's like a board. It's really, really rigid, really hard. And it's like, this is what we describe it as, board-like abdomen, board-like abdomen. So these are where there's, both of these is where the placenta, the abruption comes right off the endometrium, causing dark red bleeding with pain. And your placenta previa is painless. There's no pain. Maybe a slight cramp, but nothing, painful per se. And she has bright red bleed. Alrighty. Now, it happens, unfortunately it can happen. And so you can have infections, because of the vaginal bacteria. It can cause her to have postpartum hemorrhage. Because reason why is because our lower segment of the uterus where the placenta was attached, there's muscle fibers, but there's, the muscle fibers are weak. So there's weaker contractions that can occur. So she could have a postpartum hemorrhage. Now the placenta brevio, hypertension, preeclamptic patients are prone to that. Cocaine or alcohol use, cigarette smoking, poor nutrition. If she gets hit in the abdomen, or she has any prior history, it can happen again. And then of course, if she has folate deficiency anemia, it can happen. All right, let's see here. So how are you going to take care of a woman with excessive bleeding? Very quick, okay? So you're going to observe for pain and uterine rigidity or tenderness. That would be your abruptions. Verify that orders for blood typing and cross-match have been carried out because you may have to get blood. We usually type and cross-match for 4 units of packed red blood cells. Monitor IV infusion. Sometimes we have 2 IVs going. Prepare for surgery. If she's still pregnant when she has an abruption, we're going to get the baby out as soon as possible because you're going to monitor the fetal heart rate. I don't want the patient contracting, so I'm going to, watch for contractions, and then monitor her laboratory results, including her coagulation studies, because she could get she could have low platelets, and then administer oxygen by mask, usually 8 to 10 liters via tight face mask, and prepared for newborn resuscitation. Let's talk about another complication during pregnancy. So we're going to go from bleeding disorders now to hypertension during pregnancy. We have gestational hypertension. You have preeclampsia and eclampsia. When she has a seizure and she's got a diagnosis of preeclampsia and she has a seizure activity, that means that now the brain is involved. It turns into a more serious condition called eclampsia, okay? And it usually occurs after 20 weeks. So it could be that it be her first pregnancy, obesity, family history of gestational hypertension. If she's an AMA patient, advanced maternal age, or she's a young adolescent having her first baby, yes, this could happen. She's having twins, triplets, could happen. Chronic hypertension. She already remember the beginning coming in with hypertension that leads into preeclampsia very easily. That's why when they come in with chronic hypertension, it's like a red flag. We're watching them tremendously during pregnancy. And the chronic renal disease, of course, with the kidneys, and of course with diabetes, all kind of set her up for that. All right, so what is your manifestations of and symptoms affected by gestational hypertension? Well, hypertension, high blood pressure, edema. Usually you see the hands and the face in the very beginning. She's spilling protein now in the urine. She may have clotting disorder and central nervous system disorder, and eyes are being infected. The urinary tract may have decreased urine, okay, and she's spilling protein again. Respiratory system, and then GI system and liver. So how are you going to manage it? It depends upon the severity of the hypertension and the maturity of the fetus. So you may want to, she's further enough along and the LS ratio in the baby's lungs are good. You might be delivering her early. The treatment does focus on maintaining blood flow to all her vital organs and of course to the placenta. They all need blood with oxygen. And then of course, the main thing is we want to keep the brain from being involved. So we give preeclampsia, we will treat it with magnesium sulfate, which magnesium sulfate is given to prevent a convulsion, to prevent a seizure. That's why we give magnesium sulfate. So you're going to restrict her activity. You're going to always do fetal surveillance tests on the baby, maybe doing a non-stress test, blood pressure monitoring, daily weights, checking urine for protein, and the drug of choice would be magnesium sulfate because it affects the central nervous system. So therefore it's good because it decreases the risk of seizures. Okay, that's what we give it. If you get too high of a magnesium sulfate level, you're gonna have calcium gluconate because that does reverse the effects of the magnesium sulfate. So that'd be a bad sign. And of course, antihypertensives. All right, we're going from that right into bleeding incompatibility. So we have an Rh negative mom and an Rh positive baby. Okay, their blood should not mix. When the blood mixes, it's not a good thing. Okay, because then mom will make mom will make these antibodies. Okay, and these antibodies will cross the placenta and they'll destroy the baby's erythrocytes. Okay, and that can lead to severe anemia in the fetus, which a baby can be born with a condition called erythroblastosis fetalis. And so we don't want this to happen. Okay, so we don't want this to happen. We don't want these antibodies to cross the placenta because it will, when the fetal blood mixes with maternal blood, this is what happens. And this is a mom who's negative and here baby's positive. So mom's body, makes these little warriors I call, or antibodies, and they go after these positive cells here. Okay, and it will kill them off. All right, baby become very, very anemic, baby becomes very sick. So what can we give mom? We're going to give her RhoGAM. RhoGAM is to be given about 28 weeks and then within 72 hours after delivery to the mom, okay, before she goes home. Okay, now if she has any kind of test, what the amniocentesis, we're going to give her RhoGAM. Whenever there's any kind of bleeding that's occurring in the woman, we're going to give her RhoGAM because it could be a chance that fetal blood and maternal blood could mix, and we don't want that to happen because you do not want the maternal anti-Rh antibodies to cross the placenta and destroy the baby's erythrocytes. Okay. Let's see here. How about we talk about glucose metabolism? Okay, don't forget hormones. The placenta puts out estrogen, progesterone, HPL, and of course HCG. They all have an effect on the body on the glucose metabolism in the mom. So what happens with gestational diabetes? If a woman cannot increase her insulin production, then she'll have periods of what we call too much blood sugar, right? Hyperglycemia. And because the fetus is always taking and drawing glucose from the mom, she could also then have periods what we call hypoglycemia. And just between meals and especially at night. So that's why it's good to give mom like a glass of milk before she goes to bed, something so that she doesn't have periods of this hypoglycemia. And during the third trimester, don't forget the fetus is at risk for organ damage from periods of too much sugar coming in because fetal tissue has increased too. And the fetal tissue has increased the tissue resistance to maternal insulin action. So these are factors that are linked to gestational diabetes. So she starts out being obese. She can have that. A large infant, especially if she had a history of a large infant, like a baby that's maybe weighs 9 pounds or greater. If she's at the maternal age, and she has up their AMA, if she's had previous unexplained stillborn or stillbirths, or infant having congenital anomalies, those are things that have linked to gestational diabetes. I'm thinking our type 1 diabetics, we're always concerned about fetal anomalies with our type 1 diabetics coming into the practice. So we want to make sure we get good hold of their, their amount of sugar circulating in their body and insulin. Let's see, if they've had a history of previous pregnancy, they have to be very careful about maybe getting this again. If they have a positive history of maybe diabetes in the family, okay, and if they have a fasting glucose that's over 126 milligrams per deciliter, or post-meal glucose over 200, they also linked to gestational diabetes. And this is our macrosomic baby here. You can see big baby, okay, big shoulders, big head. This baby is in the NICU for at least 24 hours to be monitored, because this baby could have a serious problem after birth of hypoglycemia, low blood sugar. So what's your treatment? Okay, mom's diet, the first line of management, monitoring her blood glucose levels, ketone monitoring, and then exercise and fetal assessment. The care of the neonate whose mother has gestational diabetes. Gotta be careful of the baby after birth. I talked about hypoglycemia, okay? Hypoglycemia can lead into respiratory distress in the newborn. And then you can have an injury related to macrosomic, big baby, the head may come out, you may be trying to get this baby out vaginally. So the head comes out, but then the shoulders, remember I told you the shoulders are quite large, quite here, see that shoulder? That may be very hard to get through a vagina, especially even if you cut a 4th degree episiotomy, which is all the way down to the anal sphincter, you still may not be able to get the shoulders out. So this baby's clavicle will probably have to get broken in order to get this baby delivered, okay? That's why that kind of baby, I would like to see that baby by cesarean, delivered by cesarean. And then, like I said, the baby probably closely monitor for at least 24 hours after birth. Maybe have to get some blood glucose levels monitoring. Maybe baby's going to have IV and just going to be watched, because hypoglycemia, it is very, very dangerous. And so you want to measure this blood glucose level and make sure it doesn't get below like 45 milligrams per deciliter, because hypoglycemia leads into respiratory distress in the infant. Okay, but we can encourage breastfeeding, which is a good thing. Okay, moms who have heart disease, they are at increased levels of clotting factor, okay? Remember, during pregnancy, increased risk of thrombus. So just think, if a woman's heart cannot handle that increased workload that we talked about, then she can go into congestive heart failure. She goes into congestive heart failure, who's going to suffer also is the fetus, because the fetus is going to have reduced placenta blood flow, okay? Remember, whatever happens to mom affects the fetus, okay? So what are my signs of congestive heart failure during pregnancy? Well, they're going to have persistent cough. Their lung sounds may sound moist, fatigue, okay, even fainting or exertion, difficulty breathing, orthopnea, severe pitting edema of the lower extremities, palpitations, and changes in fetal heart rate. Okay, so what's my treatment? She's going to be under the care of an obstetrician and cardiologist. And priority care is limiting physical activity, okay? Some drug therapy, may have some anticoagulants, may have some diuretics, may include some beta androgenetic blockers, things like that. Vaginal birth is preferred because whenever you do a cesarean, you're putting a patient risk for infection and then complicated with respiratory. So you don't want to do that to this lady. She's already compromised as it is. So try to get a vaginal birth out of it. Because there's infection, I'm thinking also endocarditis, which is very severe, and it can affect the valves in the heart. Okay. Anemia. Anemia, there's like two different types. You have iron deficiency and folic acid deficiency. And, you know, like, you remember in the beginning, the prenatal care, we're gonna get an H&H, a CBC. We're gonna find out exactly what's going on with this mom and make sure she gets proper nutrition so that she doesn't go down, because in pregnancy, blood can actually decrease like 10 to 14 grams per deciliter. Not good. All right. On the nutrition, they are easily fatigued. They have skin and mucous membranes are pale. We talked about that. Shortness of breath, pounding heart, and rapid pulse. All right, so let's now talk about a little bit about infections. So the acronym TORCH is used to describe some infections that can be very devastating to the fetus. And you see here, rubella. We've already talked about rubella quite a bit. Another one we're going to talk about is toxoplasmosis, CMV here, which is cytomegalovirus, and then of course herpes. And also you got, you know, the other infections that can be transmitted to the baby. You have syphilis, gonorrhea, chlamydia, trichomonas, and condylomata acumata, which is genital warts. Those are things that have a risk of a transmission to the fetus. So we don't want that. That's why in the beginning, when we got our HIV against a virus that causes AIDS, it just cripples the immune system and the infant can be infected. Okay, so what we do is you have an HIV when she comes into that first prenatal care visit, and we find out if she's positive or negative. If she's positive, then we make sure she's on, you know, her medication, antivirals. And then when the baby's born, the baby could be infected because, again, it's transplacental. And so it will go right through the placenta. The virus can go right to the placenta to the infant. And then we will treat the infant. Before we even know that the infant is positive or negative, we're going to give the baby antivirals when it's born, because the sooner you give it, the better. Okay, everything in this instance, the sooner mom's treated, if she's HIV positive, the better it is for the fetus. Okay, she cannot breastfeed because it does go through the breast milk. So what are you going to do? What's your nursing care? Educate the HIV positive woman on methods to reduce the risk of transmission to a developing fetus and infant. Pregnant women with HIV AIDS are more susceptible to infection, as we know, because it just depletes the immune system. And then breastfeeding is absolutely what we call contraindicated for moms who are HIV positive. That's a good test question. Now, the next one we're going to talk about is toxoplasmosis. This one is in contact with cat feces or raw meat. It is transmitted through the placenta, and it has a lot of bad things that can happen to the baby. Low birth weight baby can have enlarged liver and spleen, jaundice, anemia, inflammation of eye structures, or neurological disease. Not good. So what are you going to do is cook all the meat thoroughly. You cannot eat raw meat. And some people do eat raw meat. It could be a cultural thing, but they can't do when they're pregnant. It's too risky. And then, of course, wash your hands and any kind of kitchen services after handling raw meat. And then avoid uncooked eggs and unpasteurized milk. If you have, you know, a lot of people have these shakes and they put uncooked eggs in it. You can't do that anymore. No, no, no. Wash your fruits and vegetables very well. And of course, avoid materials that have any kind of cat's feces. Again, going back to that first prenatal visit, remember I am going to ask her, do you have any animals in the house? She says, yes. I said, well, what kind of animal you have? I have cats. Okay. How many cats do you have and who handles the cat litter? And if she says, I handle the cat litter, no, you have to stop that immediately, because there is a high risk of this transfer of this parasite, toxoplasmosis. It's deadly to the baby. Another one that's bad for the baby is group beta strep, or GBS. Every woman gets tested around 36 weeks gestation for this. It lays down in the cervix, in the uterus, and mom's rectum. So we will do a swab, and what happens is that we don't want this baby to come through a vagina that's positive for group beta strep, because moms don't know they have it. They're asymptomatic. There's nothing to tell them they have it, but we do a swab, we can pick it up. And if we pick it up during labor, we can give mom antibiotics, and that will help reduce any problems in the vagina, and babies can come through the vagina and won't be very sick. Before we were testing every woman, we would have babies that got sick after delivery, and they would have respiratory distress. And some babies actually did die from the GBS environment. So, you know, we're going to treat with penicillin, and we're going to be pretty aggressive and make sure that this baby doesn't get sick. Urinary tract infections, more women are prone to them. Basically, you want to go over some self-cleaning action. We talked about what happens to the urinary structures during pregnancy. We want to make sure that she's emptying completely, and we want to ask her, do you feel like you have a good stream? Are you emptying completely? Because if she has any kind of urinary stasis, that can lead to a urinary infection. What we're going to do is try to get her to drink lots of water. Remember, we told them to do so. And if you don't get cystitis, we don't conquer that in the early stages, it can travel up to the kidneys, and then it's called pyelonephritis. Not good. All right, this slide goes over some environmental hazards during pregnancy. Again, we have some 3 basic categories. Now, bioterrorism in the pregnant woman, you know, things can happen. It can be transmitted from person to person, or it can be spread by food and water, and it can be spread by manufactured weapons designed to spread disease. Well, we don't want to think about that, do we? But these are different categories, A, B, and C. And then, of course, some other hazards could be substance abuse. Okay, remember, anything mom takes in goes right to fetus, and then alcohol, and too much of consuming alcohol, too much alcohol can cause the fetus to we'll call a funny looking kid, but you know, has a real the lip is really small, and baby's addicted to alcohol. Okay, trauma during pregnancy want to keep out, but it could be an automobile accident, could hurt the fetus. Homicide, unfortunately, and suicide, battering, you know, intimate partner violence, mom receives blows to the abdomen, can cause her to abrupt, have placenta abruption, and it's just horrible to happen in pregnancy. All righty. If a woman complains that she is being abused during pregnancy, information should absolutely be confidential, because her life could be in danger if her abuser learns that she has told anyone. Just be very careful, and you could refer to some local shelters. And but with this kind of patient that's intimate partner violence is there, you know, it's up to her. It's up to the woman alone if she is going to leave him or not. All right, so that's the end of chapter 5. So let me just stop sharing, and I just want to say thank you for those that were attending in the beginning, and I hope you enjoyed the review on all these chapters. Make sure that you have done your reading. Make sure that you read the key points at the end of each chapter. Make sure that you have looked up the key terms and test yourself on the key terms. That's really good. And then there's also the resource page that we have put on Canvas under announcements for week 1, 2, and 3. And there's great practice questions. Go over those practice questions and see if you can answer them. If you can't answer them, then you need to go back into the chapter and look up the answers, okay? Because those are really good practice questions, and this will get you well prepared for the exam. Okay, all righty, I'm going to say goodbye and thank you very much. This is Professor Dunham. Have a good day.